2 million brain cells die every single minute that a stroke goes untreated. Not eventually, not over hours. Every 60 seconds that passes without intervention costs you 2 million neurons that took decades to build, that store memories you made when you were 7 years old, that coordinate the movement of your hands, that process the faces of people you love, that contain every skill you have ever learned and every experience you have ever had. 2 million per minute, 120 million per hour, and the average time between the first symptom of a stroke and arrival at a hospital in the United States is 3.5 hours. You can do that math yourself. This is what a stroke actually feels like, and why the window between the first symptom and the last chance to save your brain is one of the most consequential races in all of medicine. Your brain is the most metabolically demanding organ in your body. It is 2% of your body weight and consumes 20% of your oxygen and 25% of your glucose. It has essentially no energy reserves of its own, no fat stores, no glycogen depot worth mentioning, which means it is entirely dependent on a continuous, uninterrupted supply of oxygenated blood to function. Stop that supply for 10 seconds and you lose consciousness. Stop it for 4 minutes and brain cells begin dying in significant numbers. Stop it for 10 minutes in a specific region, and the damage becomes permanent and catastrophic. Your brain is running the most expensive metabolic operation in your body on the tightest possible supply chain with zero buffer inventory, and the consequence of any interruption to that supply chain is immediate, severe, and in many cases irreversible. A stroke occurs when that supply chain breaks down. There are 2 fundamental types, and they feel different, progress differently, and kill differently. An ischemic stroke, which accounts for roughly 87% of all strokes, occurs when a blood clot blocks an artery supplying blood to part of the brain. The brain tissue downstream of the blockage is cut off from oxygen and glucose and begins dying. A hemorrhagic stroke occurs when a blood vessel in the brain ruptures and bleeds directly into brain tissue. The bleeding itself destroys neurons mechanically, and the surrounding tissue swells in response to the presence of blood, compressing additional brain regions. Both are catastrophic, both are time-critical, and both announce themselves in ways that are distinctive enough that neurologists have a simple acronym to describe the warning signs: FAST, face drooping, arm weakness, speech difficulty, time to call emergency services. The acronym exists because the symptoms are that consistent and that recognizable, and because the single most important variable in stroke outcome is how quickly the person experiencing it gets to a hospital. So let's say you are having an ischemic stroke. The most common cause is a clot that formed elsewhere in your body, most often in the heart in people with atrial fibrillation, an irregular heart rhythm that allows blood to pool and clot in the cardiac chambers that travel through your bloodstream and lodged in a cerebral artery too narrow for it to pass. The clot is now blocking blood flow to whatever region of brain that artery supplies, and the first thing you notice is not pain. Stroke is almost never painful in the way that a heart attack is painful, or a ruptured aneurysm is painful. The brain tissue itself has no pain receptors. The brain cannot feel itself dying. What you notice instead is absence, the sudden disappearance of something that was there a moment ago. If the stroke affects your motor cortex, you notice that your arm is not working. Not painful, not tingling exactly, just not responding the way it should. You try to pick up a glass and your hand does not cooperate with the instruction your brain is sending. The signal is leaving your brain, but it is not arriving at your arm because the neural pathway that carries it passes through tissue that is no longer receiving adequate blood flow. You try again. Nothing. You look at your hand as if looking at it will help, and your face, if you could see it, has dropped on one side because the motor cortex that controls the facial muscles on the opposite side of your body has lost its blood supply and the muscles have simply gone slack. Not tense, not spasming, slack. The way a marionette goes slack when you drop the strings. If the stroke affects your speech centers, Broca's area, which produces speech, or Wernicke's area, which processes language, the experience is profoundly disorienting in a specific way. You know what you want to say. The thought is completely clear. The words are right there, formed in your mind, ready to be spoken. But when you open your mouth, something different comes out. Or nothing comes out. Or what comes out is recognizable as language-shaped sound, but is not the words you intended. Wernicke's aphasia, damage to the language comprehension area, produces something even stranger. You speak fluently. Words come easily. Sentences form and emerge at normal speed. But they are the wrong words, and you do not know they are wrong because the part of your brain that would recognize the error is the part that is dying. Patients with Wernicke's aphasia will have entire conversations that are syntactically correct but semantically meaningless. Real words arranged in grammatical structures that convey nothing. And they will believe they are communicating perfectly until they see the confusion on the faces of the people listening. Imagine trying to tell someone you are having a stroke and being completely unable to understand why they cannot understand you. If the stroke affects your visual cortex, you may lose vision in part of your visual field, not blurring, not dimming, but a clean absence. A section of your vision simply not existing anymore. Not dark, not blocked, just gone in the way that your blind spot is gone. Your brain not processing the absence as absence because there is nothing left in that region to process anything. People with stroke-related visual field cuts frequently do not notice them initially because the brain, remarkably, partially compensates for missing visual information by filling in from surrounding areas. You may be looking directly at something and not see it because it falls in the region of your visual field that no longer exists and your brain has papered over the gap. The progression depends entirely on the size and location of the affected artery, and whether the clot dissolves on its own or is dissolved by treatment. A small clot blocking a small branch artery may produce symptoms that are minor and temporary. A transient ischemic attack, sometimes called a mini-stroke, where blood flow is briefly interrupted and then restored, and the symptoms resolve within minutes to hours. These are critically important warning signs because roughly 10% of people who have a TIA will have a full stroke within the next 3 months, and the risk is highest in the first few days. A large clot blocking a major cerebral artery produces massive immediate infarction, the death of large volumes of brain tissue within minutes, and the consequences are catastrophic and immediate. The middle cerebral artery is the most commonly affected in large ischemic strokes, and its territory covers a significant portion of your motor cortex, sensory cortex, and in the dominant hemisphere, the language areas. A complete middle cerebral artery occlusion produces contralateral hemiplegia, complete paralysis of the arm and leg on the opposite side of the body from the affected hemisphere, along with facial droop, gaze deviation toward the side of the stroke, and in dominant hemisphere strokes complete aphasia. You are conscious, you are aware, you can see and hear the people around you, but you cannot move half your body, you cannot speak, and depending on the extent of the damage you may not be able to understand what is being said to you. You are locked inside a body that has partially stopped responding to you, and a communication system that has partially stopped working, and you are watching the people around you trying to understand what is happening, while you are unable to tell them. The hemorrhagic stroke is a different experience, and in many ways a more immediately dramatic one. You will remember from the brain aneurysm video that a ruptured cerebral aneurysm produces the thunderclap headache, the sudden catastrophic pain that arrives at full intensity in 0 seconds. A hemorrhagic stroke from a ruptured arteriovenous malformation or from a hypertensive bleed, where chronically high blood pressure has weakened an arterial wall to the point of rupture, produces a similar sudden onset headache, although typically not quite as instantaneous as the classic aneurysm thunderclap. The blood that escapes into brain tissue destroys neurons mechanically as it forces its way through them. The surrounding tissue swells in response to the irritating presence of blood, cerebral edema, and this swelling compresses additional brain regions beyond those directly affected by the bleed. The intracranial pressure rises, consciousness deteriorates, nausea and vomiting are common from the pressure effects on the brainstem. Seizures occur in a significant percentage of hemorrhagic strokes from the direct irritation of blood on cortical neurons. Here is the treatment window and why it is so brutally unforgiving. For ischemic stroke, the primary treatment is tissue plasminogen activator, TPA, a clot-dissolving drug that can restore blood flow to the affected brain region and dramatically improve outcomes. But TPA has a treatment window of 4.5 hours from symptom onset. After 4.5 hours, the risks of administering it, primarily the risk of converting an ischemic stroke into a hemorrhagic one by dissolving the clot and allowing blood to flow into already damaged tissue, outweigh the benefits. 4.5 hours from the first symptom, that is the entire window. And that window includes the time it takes you to recognize that something is wrong, the time it takes someone to call emergency services, the transport time to a stroke-capable hospital, the time for imaging to confirm the diagnosis and rule out hemorrhage, and the time to administer the drug. Every minute of delay anywhere in that chain is 2 million more neurons that cannot be saved. Mechanical thrombectomy, physically removing the clot with a catheter threaded through your arteries to the brain, has extended the treatment window for certain large vessel occlusions to 24 hours in carefully selected patients. This represents one of the most significant advances in stroke treatment in the past decade and has saved and improved countless lives. But it requires a comprehensive stroke centre with interventional neuroradiology capabilities, and it requires getting there in time. The recovery from a significant stroke is one of the most demanding and most individual processes in medicine. The brain has a remarkable capacity for neuroplasticity, the ability to rewire itself, to recruit undamaged regions to take over functions previously performed by damaged ones, to rebuild neural pathways around the areas of infarction. But this process is slow, effortful, and incomplete. Motor function that was lost may partially return over months of intensive rehabilitation, as the brain recruits adjacent motor cortex to compensate. Language that was lost may partially return as the non-dominant hemisphere takes over some language processing functions that were previously exclusively managed by the damaged dominant hemisphere. Partially, not completely, not always. And the process requires sustained effort and intensive therapy that is physically and emotionally exhausting in a way that is difficult to convey to someone who has not experienced the frustration of trying to relearn how to perform actions that were automatic for decades. Some stroke survivors describe the experience of recovery as living in a body that used to be yours. The intentions are familiar, the thoughts are clear, but the execution, the translation of intention into action, has been disrupted in ways that require conscious effort for things that were previously unconscious. Walking requires attention, speaking requires effort. Reading, which was once effortless, may require concentration that leaves you exhausted after a paragraph. The person doing the rehabilitation is working harder than they have ever worked in their life to achieve outcomes that a healthy brain performs without any effort at all. and they are doing this work while also processing the psychological weight of what happened. The sudden violent interruption of the life they had, the uncertainty about how much function will return, the grief for the version of themselves that existed before the clot. Stroke kills 1 in 6 people worldwide. It is the second leading cause of death globally and the leading cause of serious long-term disability. Every 40 seconds, someone in the United States has a stroke. Every 4 minutes, someone dies from one. The people who do best are the ones who recognize the symptoms immediately, called emergency services without hesitation, and reached a stroke-capable hospital within the treatment window. The people who do worst are the ones who waited, who thought it would pass, who did not want to make a fuss, who drove themselves instead of calling an ambulance, who arrived at the hospital 4 hours after the first symptom when the treatment window had already closed and 2 million brain cells per minute had been dying for 4 hours. Know the signs: face drooping, arm weakness, speech difficulty, time, and they were gone 2 million cells at a time.